Hello, everyone, and welcome. Welcome to the 2021 NCCNN Study Day that's being brought to you this afternoon by Bowel Cancer UK in conjunction with the NCCNN, sponsored this year by Servier. My name's Catherine Winsor, and I'm Director of Services and Support at Bowel Cancer UK. And I'm really pleased to say I'm joined by Genevieve Edwards, our CEO for the afternoon. And actually, Jen's going to kick us off by welcoming everybody and just setting the scene for us for this afternoon.
Oh, thank you, Catherine. I'm so excited about this afternoon. Catherine and I have been waiting for this all week on our sofa, our lovely sofa, which we've set up ready for this afternoon. And firstly, can I just say hello to all of you? We've got a record number of you joining us this afternoon. More people than we've ever had at one of these events. Over 300 of you have registered. And we are so delighted and so grateful that you've taken time out of what we know are enormously busy schedules to attend today. So our promise to you is that we will make every minute count. We've got a fantastic agenda lined up for you with expert speakers, so many opportunities for you to get involved, and our thanks again to our wonderful team who put this together this afternoon and our steering group. We're going to finish the afternoon with the Gary Logue Awards, which is such a special time for us to celebrate and reward the UK's best colorectal cancer nurses. Now, every year we identify and honour the achievements of colorectal cancer nurses who make such a huge difference to both the lives of their parents and of you, their colleagues, right across the UK. So I'm so looking forward to that. We've got a very exciting ceremony lined up. In the meantime, I just want to really highlight the importance of each and every one of you, the NCCNN, to us at Bowel Cancer UK and our work. Working with you absolutely means that we are relevant and offering the right support to our patients and making sure that what they need, they get. And that's no easy feat, is it? And especially in the last year, when everybody's working, you know, it's been such a challenge for all of us, but also for our patients who've seen their world turn on its head and trying to navigate bowel cancer in the teeth of a pandemic we know has been incredibly difficult, and it's been so difficult for all of you to continue to provide that excellence of care which you have done. I just wanted to say, and from Catherine and I and everybody at Bowel Cancer UK, how much we value our working relationship with you and how much you bring to the work and the support that we can provide to bowel cancer patients. Now, I'm just going to finish because we've got a lot to get through, but I just want to tell you a little bit about our strategy and plans for 2022. And we can talk about this in more detail another time. But really, one of the things that I'm very aware of, and Catherine and I have been working with, is to see how we can increase the support for more people with bowel cancer and add real value to patients right from the start of their journey with bowel cancer through to hopefully surviving and thriving at the other end. And so I'm really delighted to say that we've just appointed a clinical lead. And she's going to be joining us in a couple of months' time. She's going to be working with us on the odd day or two in the run-up to her joining with us. But our clinical lead post was something that we've long wanted to invest in, because it's so important for us that we can develop the right clinical front door for patients to step through when they first suspect that something might be wrong or get that diagnosis of bowel cancer. And again, we would love to co-produce what that clinical front door looks like with you, as well as with our patients. So exciting plans for next year, really exciting. But for now, we've got a great afternoon, and I'm going to stop talking and hand back to Catherine to kick us off.
Thanks, Jen. Jen mentioned our fabulous steering group, so I just want to officially introduce you to hopefully some familiar faces that are going to be popping up throughout the course of the afternoon. So these were people who answered our shout out in the NCCNN Facebook group and were up for coming on board to help us plan the agenda, find speakers, and be the judging panel for the Gary Logue Awards. So those guys have worked really hard with us over the last few weeks. So I want to say welcome and hello to them, but I also do want to say thank you for all your hard work over the past few weeks and months getting us to this point. So our steering group this year was made up of Dr. Claire Taylor, your chair at NCCNN, Macmillan nurse consultant in colorectal cancer at London North West University Healthcare Trust and visiting lecturer at King's College London. We then have Philippe, who is advanced nurse practitioner in colorectal surgery and lead nurse for RIG and PEG devices at the Royal Marsden NHS Foundation Trust. And we have Tracy Becker, who is lead specialist nurse at Oxford University Hospitals NHS Foundation Trust. So you will see them popping up and being part of the proceedings, but I just wanted to introduce them up front. There's also always the bit where someone has to go through the really boring housekeeping bit, and it's me this time, Jen.
Short straw.
So, yeah, short straw. So agenda for today, if we can have the agenda up. My glamorous assistant. And the next one. Brilliant. So that's our agenda. We've got 4 really interesting sessions. Claire's going to lead one on how Bowel Cancer UK and NCCNN can work even more closely together to support. And then we've got Dr. Rebecca Muirhead talking to us about radiotherapy. We've got Laura Monje-Garcia talking about living with an inherited colorectal cancer syndrome. And then Sam Glover is going to be talking to us about the challenges and psychological impact that the pandemic has had on staff working within the NHS. Then I'm going to do a shameless plug for Bowel Cancer UK services, tell you a little bit about what we do and how we can help your patients. And then it's into the Gary Logue Awards. So around all of those sessions, there are lots of ways that you can take part. And there are some things I just want to draw your attention to. If you haven't already discovered the chat box, if you move your mouse across the screen, a toolbar will come up at the bottom and one of those will be labeled chat. If you click on that and make sure you're posting to everyone, you can just type messages to everybody, say who you are, ask, tell us what the weather's like where you are, just put some information in that box. Tell us what's interesting, tell us if you'd like more information about something, and give us feedback as we go. We get to see all of those comments afterwards, and feedback's really useful for these events. Next to, or 2 away to the left from the chat box, is the Q&A box. And this is where we'd like you to put questions to the speakers during the sessions. If you try to remember to put your questions in that box, because that's where Jen and I will be taking the questions from that we'll ask the speakers. We will try to cover as many questions as possible, but we are up against it time-wise. So any questions we can't answer or don't get round to answering in the session, we will follow up afterwards with our speakers and send you the answers. We are recording today's webinar and it will be available on our YouTube channel after the event. So we will be emailing you out the link afterwards. So if you want to watch things again or have to step out for part of a session and miss a bit, or you just want to share it with colleagues, then we would encourage you to do that. And then there's the dreaded evaluation form. Collective groan, I think, around the UK. We will be sending you out a link to the evaluation form after the event. The evaluation is really important for us because if you can tell us what we do well and what you'd like more of or what you'd like us to do differently, it really helps us make the best use of our time with you at events like this, and also helps us get the funding in place for future events. If you want your certificate of attendance, then you have to fill out the evaluation form, which seems like a really fair trade to me, Jen.
Yep, fair, completely.
So Jen mentioned earlier getting involved, and so now's your first opportunity. Any minute now, a poll is going to appear on your screen, hopefully, asking you just a couple of questions. If you can have a go at filling them in. So we want to know where you're based and whether or not you are watching on your own or whether or not there's a number of colleagues with you or friends. So if you can just have a few seconds. So we've got a bet on that Wales will be the lowest attended of the 4 nations.
And that's not
happening.
That is definitely not happening.
Definitely not happening. And let's have a look at... So yeah, we can see, can't we? Lots of people are in groups, which is always really nice. That just gives us a sense of how many how many people might actually be watching. Brilliant. Thank you, everyone, for taking part of that. Enough of me. No one tuned in to hear from me. They might have tuned in to hear from you. I don't think they tuned in to hear from me. So I'm going to hand over to Claire Taylor. Claire, over to you.
Hello, welcome. It's so nice to be here and feel so many people in the room, even if we can't see each other. And it's a day that I always look forward to in the year, to think about all things that are colorectal cancer nursing, because let's face it, there aren't many other opportunities where that's all we think about for nursing. And so thank you for being here. It's lovely seeing where you're all coming from all aspects of the country and a variety of roles. But the one thing we have in common is that we spend most of our time looking after people with colorectal cancer. And I can't thank Bowel Cancer UK enough for being so supportive and keeping us going. I was one of the founders of the network in the late 90s, and I'm still here, and you may think, what's she still doing here? But I'm just so committed to making sure that we have these wonderful opportunities to share our speciality, to develop ideas, to network with each other. And we have been challenged, of course, by the pandemic to meet. So it's lovely for the second year, at least we have the opportunity virtually to connect. But we would like to just spend a moment to ask you a couple of important questions about how we can improve that. We're always looking for ways to support you and engage with you more. So the first poll that we wanted to share with you on this is, how can we best support you? In what ways would you like the network to support you in your role, please? If you can answer any that are relevant. So multiple answers are okay. And then the second question is, how would you most like us to communicate with you? Because we do create newsletters and we send them by email, but we're aware that not everybody's getting those emails. I think they're getting blocked by some of the servers in NHS Trust. So is there a better way? Of course, we have our web pages and Bowel Cancer UK website, and there are links from this day will be there. And we have our Facebook group, and I know that we have a fairly active discussion about posts and protocols on there, but I don't think everybody who's on the conference today will be part of that. So that is perhaps another forum for you to be thinking about joining. But is there anything else that we haven't thought about that you would like to suggest to us today? So I can't see those responses, but thank you for taking part in that, and thank you for being here today. All from me on that one. I presume we'll get the responses at the end. Is that right, Catherine?
Yes, it certainly is when we've analysed.
Fabulous. Good. Okay, so that was all I wanted to say. And I'm now going to introduce our first speaker, who is Dr. Rebecca Muirhead. She's a consultant clinical oncologist at Oxford University Hospital NHS Foundation Trust. And we've asked her to speak about the expanding role of radiotherapy to the care of patients with colorectal cancer. Rebecca is a full-time NHS clinician. She is active at a national level in the treatment of lower GI cancer and SABRE, as well as being a member of the UK SABRE Consortium, and is lead of the RCR National Guidance for Rectal and Anal IMRT. Thank you, Rebecca, for joining us today.
Do we have you there with us, Rebecca? Rebecca, are you there? No? You might be having some...
I'm so sorry, can you hear me?
Oh, yes, you are there, Rebecca. No?
I'm being told my internet is unstable. I'm so sorry.
That's all right. We can hear you now.
Do you want me to try? Yeah. Okay.
Let's give it a go, and if not, we'll think on our feet this end.
Perfect. You have a recording, right?
We do.
Yeah. I'm disabled for sharing screen. Good afternoon, and thank you. Sorry, I had a little bit of an internet glitch. I hope this goes okay. My name is Rebecca Muirhead, and thank you so much for the invitation to speak today. It's such an important meeting I didn't know existed, and I'm really glad to be able to talk to you a bit about my views on radiotherapy and colorectal cancer. We can move on to the next slide. So I'm going to give a bit of background into radiotherapy, and then I'm going to talk about 3 relatively novel indications for radiotherapy in colorectal cancer. So firstly, using radiotherapy for organ preservation. Secondly, using stereotactic ablative body radiotherapy, or SABR, for oligometastatic disease. And lastly, for re-irradiation in rectal recurrence. Radiotherapy, as I say to patients, I know some of the Oxford nurses are here, you'll have heard me say it a million times. Have you ever had a chest x-ray? Chest x-ray, that's what radiotherapy is. It's just bigger doses and pointed more accurately, but it's exactly like getting an x-ray. I think it suffers from bad press, and I think it's a real shame. Any medical student or junior doctor who spends any time in the ward with me, the first question I always ask is, how do you cure cancer? And every single one of them almost replies surgery and chemotherapy. And if they leave knowing anything, it's that chemo doesn't cure cancer. So we use chemo to maybe improve our cure rate very marginally. But if you want to cure a cancer, unless it's a testicular cancer, you've got to have radiotherapy or surgery. So I think we suffer from bad press, and that's why, you know, we unfortunately don't get as much research money as I'd like us to get. So in lower GI cancer, I think we'll all know radiotherapy is what we give routinely to the locally advanced rectal cancers prior to having a radical operation. That's what we normally see radiotherapy being used for, or palliatively for symptom control. So we'll go on to the next slide. So I was going to talk about organ preservation. Now, this is for patients, particularly patients who are not very fit and might struggle to get through an operation safely, or alternatively, patients who are looking at an APR and a permanent stoma and they're very stoma averse. So I'm going to show just maybe 2 trials in the 2 different settings. So this is the TREC trial that was in early tumours. So this was a trial run from Birmingham and Simon Bach's group. It was a feasibility study, really wanting to see whether you could randomize patients within a trial to radical surgery or an organ preservation strategy. And they had 55 patients, which was enough to demonstrate feasibility of randomization, that were randomized. And then they also collected 61 patients that were non-randomized who had organ preservation. So as you would expect, there was significantly less serious side effects with organ preservation than with surgery, so 15 versus 39%. Those patients that had radiotherapy, it was just short course in this study, and still has some abnormality left behind, went on to have a TEM. And in those TEM specimens, 30% of them had had a complete response rate to radiotherapy. So in early tumours, you know, we can cure at least 1/3 of them, because some of these patients won't have had a TEM because their mucosa looked normal. So I think in early tumours, there's a good chance we can cause a complete response just with radiotherapy. And certainly using it in combination with TEM or with contact radiotherapy, then we can push that even higher, because you can see in this group that 70% of the patients organ preservation was achieved, and 90% of the non-randomized group. So it's very achievable. The one thing I would say is we don't have a study where people were randomized between organ preservation and radical operation, that gives us survival data. So we cannot assure patients that we are as likely to cure them with an organ preservation technique. And that's the one proviso I would say, that you do have to consent these people and make them aware that there is no data to absolutely confirm that they're just as likely to be cured. But this trial, the one, or not the one good thing, but one of the many good things this trial did is they did, if we can just press the next button. So they did really good PROMs, they collected really good PROMs data, and you can see that the quality of life, blue is the radiotherapy. Quality of life is better with radiotherapy. And that was for most of the things that they looked at, apart from the one about bowel function, which was actually worse with radiotherapy. All the ones about sexual problems afterwards were more or less the same between the two groups. So I think this is really powerful data that patients can use if they're having to make a decision. What's important? Do you want to have complete control of your bowels, in which case perhaps radiotherapy is not the right thing? But this data can be used to help patients make decisions. So if we go on to the next study, that's thinking about locally advanced cancer. So the OPERA trial was a phase 3 study run by Memorial Sloan Kettering of patients with locally advanced cancers who at outset really wanted to aim for organ preservation. So they were looking at 2 different TNT regimes. So that's total neoadjuvant therapy. So that means when you just throw the book at them before your operation. And that's, you have chemotherapy by itself and then chemoradiotherapy. So they were looking at basically using those in one order and then the next. So the first arm got chemo, then chemo-rad, and the second arm got chemo-rad, then chemo. And their primary endpoint was DFS. So we look at the next. So at 3 years, the DFS in both groups was exactly the same. The metastases DFS, so your metastases-free survival, was exactly the same in both arms. But what was statistically significantly different was the organ preservation rate. So if someone at outset who has locally advanced disease says that they want to aim for organ preservation, you need to think about the order in which you're giving your treatments. So you start off with your chemo-rad and then think about chemotherapy afterwards. And then the next slide. So the last thing I thought I'd raise is the International Wait and Watch database. So this is centres from all over the world, 15 countries, who send in their data on people who've had complete response rates. So it's a bit dirty, but there's big numbers, which has its benefits, and they publish it all together. So they have confirmed what lots of smaller series have shown, that about a quarter of people who have an initial complete response rate subsequently relapse. So that's why we're very annoying about doing lots and lots of follow-up on these people so we can catch those quarter. And the other thing it showed that the distant relapse rate is really low. Now that has been shown before by the Mercury group. So that's Gina Brown's group in the Royal Marsden, who reported that if you have a complete response rate, your distant relapse rate, they showed 11%, but it's very similar. And if you think that our standard distant relapse rate for normal colorectal cancers is like 30%, then that's much less. And it shows that it's a different biology. So for some reason, this is the kind of biology of tumor that disappears with radiotherapy, is really, really responsive, and also doesn't metastasize. So there's lots of work going on, particularly with the ESCORT consortium, which is led by Tim Maughan, looking at the biology of different tumors and how they respond to radiotherapy. And could we pick out the ones that respond before we treat them? And that's all ongoing. The other really useful thing that the Wait and Watch database gave us was at what point are people relapsing? So that informs our follow-up and how long do we have to do. I mean, we started off doing 3 monthly SIGGIs for years, but I think having the knowledge that most of the local regrowths are happening in the first 3 years means that we can readjust that. And they have reported that all of the local relapses went on to have a TEM or a TME, but with a 6% R1 rate. It's difficult to know what to read into that. It may be that people don't send in data of the disasters, but relatively reassuring. So the next thing I think is worth thinking about organ preservation is what is the patient's perspective? And I've put two studies because I think there's two different learning points. So this was 49 patients, and they were all asked, how would you feel about wait and watch, which is also known as deferral of surgery, if you had a complete response? So 83% said they thought that they would consider it. They weren't particularly deterred by having to have very regular follow-up studies and having a 25% local regrowth rate. And 41% said they would be willing to exchange cure rates for a non-operative treatment strategy. Now, I think the learning point for this is if you look at the small print, what they were actually told is that with an operation, you would have a 90% cure rate. And if you had organ preservation, you'd have an 88% cure rate. And still only 41% said they would entertain that. If you've got someone who's got locally advanced disease, then you may be talking about a 50% cure rate versus a 40% cure rate. So I think the thing I learned from this is it's all about how you sell it. So I think you have to be honest about what is their stage, what is their chance of having a recurrence or a distant disease. Think about it from that particular patient and give them numbers that are relevant to them, because we all know everything is all about how we sell it. And then the next one, which I thought had a learning point, it was 57 patients and 38 volunteers, which were, most of them were family members of patients. And they had some various different scenarios. And then they were given 4 options. So APR, low anterior section, local excision of wait and watch. So wait and watch, which is another word for organ preservation, was ranked top by 36% and 50% of patients and volunteers respectively. So they were absolutely desperately keen for it. But equally, wait and watch was ranked bottom by 38 and 35% of patients and volunteers. So every patient is different, was my take-home message from this one. There is no point presuming that everybody wants this and no point presuming that nobody wants this. You have to ask them what they want, is what I took away from this one. I think that's all I was going to say about organ preservation just now. So SABRE was the next thing. What is SABRE? So it is stereotactic ablative body radiotherapy. So it's ablative. So that means it gets rid of everything that we hit in that circle. So it's equivalent to surgery, it's equivalent to ablation. So it's supposed to get rid of everything that we hit. But how do we compare to surgery and ablation? Well, I'm probably biased, but I would say I think we compare pretty well. We can hit pretty much any site. So we do bones, we do adrenals, we do lymph nodes, we do livers, we do lungs. I can't think of a site that we don't really hit. The thing that puts us off is if it's very, very close to a bit of small bowel, that would maybe put us off. But for the most part, we can hit anything. It's all outpatient. It's given in 3 to 5 fractions, 3 to 5 visits in outpatient, 3 to 5 x-rays for the patient. Doesn't require an anesthetic. And 50% of our patients don't even know they received it. So they have no side effects. And if they have any, it's usually a little bit of tiredness. So in comparison to surgery or ablation, I think we do pretty well. Next slide. So there is lots of evidence in retrospective series that patients that you operate on, ablate or SABRE, so I'll call those patients with oligometastatic disease, where you get rid of all the cancer you can see. So there's loads of series that say that they do better. But the question up until recently was, are you just picking these guys? Now, you've seen my joke before because I'm not controlling the slides. Instead of these guys. Sorry, I shouldn't laugh at my joke. But more recently, we have now got literature to support what we're doing. So if you look at the next slide, SABRE Comet has revolutionized how we think about SABRE. So this was a phase 2 study, and it was patients were randomized between SABRE or standard of care. So standard of care was like chemo or palliative radiotherapy or a period of wait and watch. It had 99 patients in it, and I have to accept there was a big different tumor types were all involved. CRC was about 1/3 of the patients in there. And if we show the next bit, so the median survival between the groups went from 2 to 4 years, and the 5-year survival went from 17 to 42%. Now, there are criticisms of this study. It was phase 2. They didn't stratify very well for the different tumour types. But to put those sort of numbers into perspective, in 2014 at ASCO, which is the biggest cancerous conference in the world, the Herceptin data was presented for the first time. And everybody at the end of the presentation got to their feet and clapped. And their median survival at 10 years went from 75 to 85%. So, I mean, these numbers, despite the criticism, that is an enormous difference to make to someone's survival, far more than any of the chemotherapies do on a very regular basis that we dish out all the time with lots of side effects. So this has really sort of revolutionized how we think about SABR, and we're using it a lot more and with evidence to back it up. So I can't remember what I have next. So who does well? So the people that you have to pick out, it's pretty objective, and we all sit in the MDT and we think about all of these things. So people that do well are people with long disease-free intervals, less lesions, smaller sizes, the first time they've had a treatment of an oligometastases. Colons do better than rectums. What you're trying to do is to pick out the people where the burden of the disease is what you can see rather than what you can't see. So if someone has had an operation and 3 years later they get one lymph node, then actually probably they had some micromets. They must have had some micromets. They've been swimming around their body for a while and they didn't find anywhere right to grow. And eventually one has thought, here's someone I can grow. And it started to grow and all the other micrometastases have died away. So that person, probably most of what you can see, or if not all, is that disease. So it's absolutely worth treating that person. If it's somebody who had their operation, has just finished adjuvant chemotherapy and has cropped up 3 new liver metastases and 1 in the lung, then they must have crowds of micrometastatic disease because they've progressed through chemotherapy. They've got 2 organ disease, they've got 3 mets in the liver. So that's somebody we would never get SABR to. We would say they need second-line chemotherapy. Now that is a decision that we just have to make without having good rules as to how to make it. But it's a subject of discussion at every oligometastatic MDT, I think. Right. So and next we have. So this is something I think about a lot, is how do you talk to patients with oligometastatic disease? Some of my colleagues will tell someone that I've resected or I've SABR'd liver metastases, that's you cured. But the vast majority of these come back somewhere else. So they end up being cured and they're on a high, and then it comes back and they're on a low, and then they're cured again and they're on a high, and then it comes back and they're on a low. I think that's a very difficult way to live. So I'd be very grateful for thoughts or input about, this is what I say. I say we're trying to get rid of all the cancer that we can see. But to have got from one place to the other, it must have gone through your system. And therefore, the chances are, the majority of patients, it does come back. And this is just another way that we have to control the disease over what I hope will be a period of years. When we do treat oligometastatic disease, the 5-year survival is 40%, and a 10-year survival is 20%. And by the time you get to 20%, you're probably cured. So we do cure about 20% of them, but equally we don't cure 80% of them. So I think it's only fair to say, listen, the likelihood is this will be a disease that we manage, and we manage with SABR, with operations, with chemo for a period of years. I do say there is a small chance we will cure it, but that is small. And the last thing I always end the conversation with is, do you need support? Because that's a very difficult thing to have in your head and to deal with. And we always go from anything from a cup of tea at Maggie's to talk to people who know about it, all the way up to we have a psychiatrist that we refer people to. So that always forms part of the discussion. So it's useful to think about how you speak to people receiving treatment for oligometastatic disease. And next, I think I just had I promise you I didn't work very hard to find these patients. I just looked at a particular year and picked the first few. So this lady I treated in Stoke, she had a PA node 2 years after her anterior resection. So she's probably somebody who we do have an outside chance of curing. She had SABR in 2018, she's disease-free to date. And the next one was a bit unusual. So this lady had a T2 colon cancer. So that doesn't usually metastasize, with no nodes. And a year later, she got a tibial met, so in the bone of her lower leg. And nobody believed it would be colon cancer. So we actually biopsied it, and it was. It was growing really quickly. So they were talking about giving her palliative radiotherapy, but it was oligometastatic disease. Surgeons didn't want to touch her, so we SABR'd her. And about a year and a half later, she had PET avidity, which she was being looked after at Peripheral Hospital, and they didn't know that post-SABR it can stay PET avid. And they resected it, and actually she'd had a pathological CR, so it was an operation she didn't need. But anyway, so a year and a half later, she's had a pathological CR after her SABR. And then the last one is a young chap who had CRT and exenteration, and then had quite a big PA recurrence that was going to require his kidney to come out. It was going to be a big old operation that the urologists were not particularly keen to do because they didn't even think they would get it all out. So we gave him SABR in 2019, and he's back at work looking after his own family. He's someone who did need to see a psychiatrist, but and struggled a lot at the beginning, but is now very, very well and completely discharged from that care. So that's all I was going to say about SABR. And then re-radiation. So you guys will have seen patients with locally recurrent rectal cancer, and I'm sure you all agree it's absolutely horrific. So the next button will show you all the horrible things that happen with locally recurrent rectal cancer. It's just miserable, and palliative care don't know how to look after it, so they ask us. We don't know how to look after it, so we ask them. It's very, very difficult to manage. But go on to the next slide. Re-irradiation is something that we as oncologists and our college have always told us we should never do. It's bad. You know, it causes lots and lots of side effects, makes people really unwell. But radiotherapy's come on a lot, and it's very different than it used to be. So we are in a position to be able to re-irradiate and re-irradiate safely. So I would say that there are 3 indications in which I would re-irradiate in rectal cancer, recurrent rectal cancer. So the first one is on the next slide, and it's for symptom control. So Rob Gwynne-Jones in Mount Vernon did, along with some other colleagues, did a systematic review of some papers, of 48 full text papers, and found that 82 to 100% had improved symptoms of re-irradiation. If you're using about 30 gray, it lasts about a year. So all I would say is think about how long do you think these people will live, and treat either anything 25 to 30 gray, depending on how long you want their symptom relief to last. And then the next slide is about SABR as definitive treatment. So exenturations for local recurrence are tough, they're morbid, and we looked at, as I'm going a little bit faster because I'm running out of time, my apologies. And we looked at 69 patients where we gave SABR instead of surgery, and our median survival match was 38 months, 2 years was 77%. Now, if you look at the Pelvex publication, which is the exenteration international group, their median overall survival with an R0 resection is 36 months. Their 2-year overall survival is 68%. So we had probably better tumours in our group, but it's not an unreasonable suggestion to make to think about SABR rather than exenteration. And oh yes, the one thing I would say is that we can make SABR better, because there were still a number of people who developed a local relapse after their SABR before last follow-up or death. So we're aiming to, myself and actually Claire Taylor have applied for money for a trial in this setting with slightly better SABR. And the last indication is pre-operatively, so before an exenteration. The important thing in the trial I've got here is this was given just 40 gray. It was a just 40 gray. So there's no doubt that the R0 rate or I'm pretty sure that the R0 rate will be affected if you give neoadjuvant radiotherapy. And the trial that we're trying to open here on the next slide, the GREC-R15 study. So that's a French study. And we're trying to get it open in the UK, which is testing neoadjuvant radiotherapy in the surgical setting. So I think the last three are just summary slides, which we can skip because they're all things that I've said before and always pick up later. And I'm not sure if I have time for any questions. Sorry, Anna.
Thank you so much, Dr. Muirhead. Rebecca, that was wonderful. Covered so many aspects of radiotherapy in our speciality. So we are actually at time. There's a couple of questions in the question box, but perhaps we can answer those through the type. Yeah, so many really topical and important clinical issues were addressed. So thank you very much for today. That was wonderful.
No problem.
I think what we might do is ask Rebecca to answer those questions, and we can email the questions and the answers round the whole group.
Okay, thank you very much.
Okay, so moving us on, Rebecca's warmed us up with some radiotherapy.
That was fascinating.
Very
Absolutely
interesting.
fascinating.
We did have to Google some stuff though, didn't we?
A little bit.
Just a little bit, yeah. Not clinicians. So now I'm going to welcome Philippe to join us as he's going to introduce the next session for us.
Thank you, Catherine and Jen. Hello, everyone. My name is Philippe. I'm an advanced nurse practitioner in colorectal surgery, and I'm here to present our next guest. Her name is Laura Monje-Garcia, and she's a nurse practitioner in familial intestinal cancer at the St. Mark's Hospital. In addition to being a nurse, Laura is also a health psychologist who has been working with patients with inherited conditions for the last 10 years. Her session will be on the psychological impact of living with the colorectal cancer predisposition and how we nurses can best support our patients. Feel free to drop your questions and thoughts in the chat box, and over to Laura.
Thank you for the introduction, Philippe. I don't know if you can hear me. Hi, my name is Laura. I'm a nurse practitioner, and I just would like to introduce you to the work that I have been doing for over the last 10 years on the psychological impact on inherited colorectal cancer and other conditions. Okay. Oh, can I go back to the previous slide? Thank you. First of all, I would like to go through what is a genetic diagnosis. Is it different? As you can see from the front page of the Times, you can see a baby that is actually not so happy. So when people undergo genetic testing, it's like predicting the future. The only thing is not going to be good news. It's going to tell you about the possibility of you or anyone that is undergoing genetic testing of developing certain conditions, some with worse outcomes than others. Before I go forward, I would like to make a distinction between two different types of genetic testing. So there is the diagnostic genetic testing that you might be familiar with. That is a patient has colorectal cancer. They are found that they possibly have a genetic condition, and they undergo genetic testing, and then they are diagnosed with an inherited colorectal cancer syndrome. This is called diagnostic genetic testing. And the other type of testing is called predictive genetic testing. This is an asymptomatic family member that has no cancer, and they undergo genetic testing to find out if they have the inherited condition that is found in the family. Okay, so what is it special about receiving a genetic diagnosis? Why is it different? Well, it doesn't affect just your patient or the patient that you have in front of you. It affects the whole family. So receiving a diagnosis of cancer already has a psychological impact. So receiving an inherited diagnosis or a genetic diagnosis is going to amplify the psychological impact due to the implications to other family members. And this can seriously affect the family relationship and dynamics. And I would like to show you a little video that actually illustrates this. So there is guilt, blame, resentment. You will be able to see it now.
She blames me for her having it.
Oh.
She blames me for her having it, and quite rightly so, because I blame my mother because she's given it to me. So, you know, I take the blame. It's an awful thing for a parent to think that he's given his kids a potentially fatal disease.
That's the end of the video, and I think what you can see from this is the family dynamics, how much they change. But especially, I don't know if you noticed, but he actually nearly choked when he was talking about how he felt, the guilt that he felt about passing the genetic condition to his children. And this is very central to a genetic diagnosis, one of the strongest psychological impacts. It's very important to be aware that if you don't ask questions to your patient, you might not find out what is going on, because we can only see the surface. We cannot see what is underneath, as you can see from here. So if you ask direct questions about how they feel and what is the experience of the inherited condition, you might not be able to find out what's going on. If you look at the psychological impact of receiving a genetic diagnosis in general, there are catastrophic events. There has been some people that have committed suicide when learning that they're going to develop a diagnosis in the future. I just want to highlight this doesn't happen in inherited colorectal cancer syndrome, but it's important to be aware that people might have extreme reaction. And what is important to know, what is it like for your patient? Is the diagnosis of cancer the worst fear of your patient coming true? Can they live with that knowledge? That's what is important. So I conducted a systematic review looking at the psychological impact of living with inherited colorectal cancer. This is a snapshot of the studies that how we shortlisted the 31 studies that we decided to include. What is important for you to know is that we decided to look at asymptomatic individuals, individuals with that cancer. So whatever the findings are for this systematic review, just remember that it will be an add-on to the psychological impact of receiving a diagnosis of cancer. So there were quite a lot of challenges when interpreting the literature, especially when you look at quantitative studies that mainly use questionnaires. So most of the studies look at the psychological impact of genetic testing, which is not the psychological impact of living with an inherited condition. And they look at different time points. So the baseline for them, it was before genetic testing, and maybe the patient was already aware that there was an inherited condition in the family, so they were not free from the psychological impact of living with the condition. Another way that they look at it is they compare people that underwent periodic genetic testing, and they compare people that receive a positive result or a confirmation of a condition and people that were unaffected. Now, because they are living within the family, and because sometimes they don't believe their results, and they also suffer from survival guilt, that is not a fair comparison if you want to see, what are the differences, and one group is actually not free from psychological impact. So not very helpful, but they did find anxiety and depression. They did find a transient anxiety after receiving the results, and going back to the baseline. As I mentioned, going back to the baseline is not free from psychological impact. The qualitative studies were more helpful helpful. They mentioned that receiving a genetic diagnosis was overwhelming. There were concerns about cancers in other family members, and it took them time to accept the result and gradually adapt to change. There was quite a lot of anxiety, especially when they were waiting for the results, and feelings of anger, guilt, frustration, survival guilt for those that receive a negative result, irritability, blame, family stigma, a different way of seeing your family, but in a more negative way, and fears of students' discrimination. The risk perception change, and the worry of family members intensify. And there is some people that cope by denying and avoiding this information, even though they know they have the inherited condition. So this is very important to take into consideration when you look after your patient. And they also mentioned that it was a burden to share the information with family members if they are the first ones to be diagnosed and they have family planning consents. Are they going to pass it on to their children? But it's not all negative. My experience over the last 10 years, when I look at the psychological impact, sometimes receiving a genetic diagnosis can give family members closure and explain why so many members of the family develop cancer. And it also gives them a way to prevent it. It gives them reassurance and control over the condition through cancer prevention programs that are available for them. For some people, it gives them certainty because they know that they have the condition and they know what to do. But this is very particular or personal to each person. And sometimes if the family dynamics are already good and there is good communication in the family, it will give them ways to cope. And then the family members will help the person that has developed cancer to cope. So quite a lot of positive impacts if the person is very well supported and there is good relationships in the family and they have a good experience of the condition. There is also negative impacts as they feel shock when they receive the information that contradicts the previous belief. They might not believe it, and that's when they will engage and avoid and denial. There could be regret as the death of a family member could have been prevented. They might feel disappointment and frustration. There is also some people, this is very personal, it might give them additional uncertainty about developing cancer, their children developing cancer, and obviously, as I mentioned, guilt about passing on the genetic condition and general concern about children, difficulty adjusting to uncertain results. Some of the results are not a clear cut. They might receive uncertain results, so they might have difficulties adjusted to that. And then some people might have complex emotional reactions. So very intense emotions. This seems to be more common on people who have past traumatic experiences of cancer. Like, for example, they have looked after a family member who subsequently died at a young age with cancer. They might experience quite a lot of guilt, self-blame, confusion, very confused. They might feel one way 5 minutes and then change very rapidly to feeling very differently about it as they're trying to make sense of their diagnosis. And negative results, as I mentioned, sometimes they are not reassuring, so they might struggle with that. And there are very poor outcomes with families in which they have poor communication and poor dynamics. And it might take away the family support or the little family support that they will have in place if it wasn't an inherited condition. So what are my recommendations for colorectal cancer CNS? Is first of all, is speak to your patients and try to find out if they have any risk factors. Like, for example, do they have a traumatic experience of the condition? Have they have several family members dying of the condition at a young age? Were they close to them? Do they have a complicated bereavement trajectory? How are their family dynamic? Is there a lot of resentment? What sort of support are they getting with family members? I suggest that in these cases, if you identify any of these risk factors, that you actually refer them to a psychologist or organize some form of emotional support for your patients, because they are going to need it. Sometimes if you don't ask, your patients might not express what is happening today. Also, if they need help contacting family members that might be at risk, or they have difficulties speaking to their family or their children about their condition so they can be tested as well, you can contact your specialized genetics unit, or you can contact us if the patient is under the family cancer clinic, and we can speak to the patients and actually find ways in which they can share the information, give the letters, or even direct them to some workshops that they organize for families to help them to share the information or to speak to their children. Also, to be aware that receiving a genetic diagnosis, that doesn't mean that they cannot have children. So there is something called pre-implantation genetic diagnosis, or PGD, which is a family planning option or IVF option, in which we make sure that the fertilized eggs doesn't have the genetic mutation, and by doing so, they don't pass on the condition. This is funded through the NHS, and if you would like to find out more about that, feel free to email me or email your specialized genetic center. And the fear to develop another cancer is well funded. So it's very important that your patients are in a cancer prevention program. If you have any questions about what that involves, or you would like to find out more to make sure that it's in place for your patients, feel free to contact us or to contact your genetic units. And as well, sometimes be aware that your patient might feel isolated if they are the first person diagnosed with an inherited condition. So charities and support groups are really useful, because they will put them in touch with people who is living with the condition. And this is really helpful, because not everyone who have an inherited colorectal cancer will develop the condition. Not everyone. So it's very important for them to know, and for them to make sure that they are under this cancer prevention program. And I would like to tell you a little bit about what's happening to the NHS. So there is a national transformation project going on through the NHS to include genomics into routine nursing practice nationally. So they have formed 7 genomic medicine service alliances, or GMSAs, to actually do this. So if you are not including or not learning about genomic, it's something that is going to happen. So the sooner you take advantage of any learning opportunities that are available to you, the better. If you ever meet anyone that works in one of the GMSAs, my advice to you is speak to them, get involved, tell them what you would like your service to look like and what do you need. Tell them that you would like to be upskilled, use this to increase your pay or to increase your banding. Take advantage of it and make sure you communicate. So is genomic relevant to you? Well, it is now with the National Transformation Project. So please do take advantage of any opportunity that is available to you. I'm just going to give you an overview of some of the opportunities that might be available to you. One of them is my colleague, Vicky Cathill, is actually been appointed as a Macmillan Genomic Clinical Fellow, and she's developing an education package for healthcare professionals in genomics and cancer care. If you would like to get involved or have your say about what that package is going to look like, or what you feel that you need, do email her. There is the email. You can find it down here. Tell her that what you would like to know in genomics and how would you like this training to be delivered. And also it gives you the opportunity to be involved. And if you would like to contribute and be involved in the panel that is actually going to develop this training, to contact her. And I myself, I work in the Lynch Syndrome Quality Improvement Project, and I have developed another training package for colorectal cancer nurses. I am developing another one for endometrial cancer nurses about Lynch syndrome. It's a very short online training that you can take in about 1.5 hours. So it's very short, and it will give you the skills that you need to identify Lynch syndrome patients. So this is some of the, the 2 flowcharts of the training. So this will be covered on the online training. And it will help you to identify these patients and refer them to your associated genetics department. And it's really useful, and that's why it's so short, because it's actually fairly simple in a way. Now, an additional part of this project is for the nurses that would like to be able to offer genetic counseling to their patient. There is an option for that, and that involves having an additional 6 workshops to actually be trained up in genetic counseling. That can also be achieved if you like, and this is going to be expected in the future of the NHS. And why is it important? I would like to tell you a little bit about Lynch syndrome. So we only know about 5% of the patients that has Lynch syndrome, which means that 95% of these patients are actually working among us, and they don't have a diagnosis, or they are not in a cancer prevention program. So we can prevent these family members from developing cancer if we actually identify these families. Muirhead was diagnosed with colorectal cancer at 29. He progressed, but he actually knew that there was a family history. He was offered genetic testing, and he was found to have Lynch syndrome. He had metastatic colorectal cancer, but he later on found out that immunotherapy actually works very well in Lynch syndrome, which is actually true. And after having the right treatment, the tumors completely disappear. And this is the impact that you can have if you actually identify these patients. He has written a book, as you can see around here. I really recommend it because it tells you a little bit about the story of and his survivorship. I place Angelina Jolie in there because there are just as many patients or more patients with Lynch syndrome than actually patients with BRCA. But we know a lot about BRCA because of the campaign that Angelina Jolie had worldwide. So I was wondering if you will be able to actually put a little bit of effort and learn a little bit more about Lynch syndrome and being able to identify your patients in your clinics. Please contact me if you have any questions. If you would like to find out a little bit more about the training, or if you would like to contact Vicky Cathill, my email address is down here. And if you would like to take the training regardless, the link to the training is just here. Thank you very much for the opportunity to present in this conference.
Thank you, Laura.
Thank you, Laura, for an exceptional presentation. And obviously, it's really, really important and interesting work that you're doing. We do have one question for you. There is, when do you recommend patients are sent for genetic testing?
So patients are identified as having possibly Lynch syndrome as soon as their immunochemistry, mismatch repair immunochemistry results are back. So as soon as you find out that the patient is eligible for genetic testing, refer them straight away. The sooner they find out, the better. They have metastatic colorectal cancer, they can have immunotherapy, that they respond extremely well, and we can prevent from every patient that gets diagnosed with Lynch syndrome, we find out that another 3 family members have Lynch syndrome, so we can prevent cancer in another 3 family members. So it's really important that you do it as soon as possible. I actually spoke to Muirhead, and I asked him this question myself just because of the psychological impact. And he told me that as soon as possible, that he would have preferred to find out even before. So.
Fantastic. Any more questions, Catherine?
No, just lots of people wanting the link for the online training, which we will send round afterwards.
Fantastic. Well, thank you so much, Laura, for
Thank you.
great presentation. And we'll move on to our next presentation.
So over to you, Tracy.
My name is Tracy Becker and I'm lead colorectal specialist nurse at Oxford University Hospitals NHS Trust. It's my pleasure today to introduce Sam Glover, who also works at Oxford Hospitals. She's psychological medicine occupational therapist. She qualified in occupational therapy at Oxford Brookes in 2015 and has then worked on rotation in elderly care, palliative care in Southampton, going on to work in Gosport in the community team. She joined the team at the OUH in 2017 and her current role is working in psychological medicine. She's going to talk to us today about the challenges and psychological impacts of the COVID-19 pandemic on clinical staff. Thank you, Sam.
Cool. Hello, can you hear and see me okay? Thank you so much for inviting me to speak today. It's a real honour and I've really enjoyed the talks that have already been. It's really, really interesting to hear everyone's kind of perspective on the different subjects. So I'm going to talk to you a little bit about the staff support, the staff challenges, and the kind of psychological and emotional impact of the pandemic as observed by us at Oxford. Obviously, we can only speak for our trust, but I imagine there'll be similar kind of themes and feelings across the country. So firstly, just to talk about what we kind of offered from the start, really. So we were quite proactive in terms of, obviously the March lockdown happened, and I think it was kind of early Aprilish time we kind of got together as a department, psychological medicine, just to see what we could offer for the staff across the John Radcliffe, the Churchill and the Knock as well. I'm based at the Churchill, so our team, we are psycho-oncology, so we assess and treat patients with cancer, in Oxfordshire. So we treat them for depression and anxiety alongside their cancer. So we're very much based here at the Cancer Centre, so that's where our kind of focus was for staff support. But obviously the psychological medicine team at the JR did lots of stuff as well. So from our perspective at the Churchill, so one of the first kind of physical things we did was create a wellbeing room, which was really a space where staff could go, ward staff and kind of outpatient staff, to sit and kind of, you know, have some time away so they could take their breaks in there. But there was also things in there like arts, craft, music, you know, just so that they could have a bit of time away from the work environment and the stress. And also after their shift, I mean, most people did tend to want to just go straight home, but if they did want a bit of quiet time after their shift, that's somewhere they could go as well. And then obviously one of the biggest challenges for us was that we couldn't really offer that much face-to-face or group support, particularly in the early months. So we did have to get very used to technology, which, as you can see, I'm not great at myself. So we used Teams to organise support sessions for the oncology and haematology inpatient staff group, so the nurses. My manager, consultant psychiatrist, Dr. Luke Solomons, did a lot of Teams groups for the regs, for the doctors, for the pharmacists, and I did a group for the physios and the OTs, which we were able to move to face-to-face in the therapy gym later on into the pandemic, which was quite good because it was quite a big space, so that did make a difference. And then since then, obviously it's been, you know, 18 months now, so things have kind of changed month on month, but we do still offer the supervision sessions for the CNSs semi-regularly, just to talk through any kind of concerns they have. And then again, at the beginning of the pandemic, I don't know what other trusts did, but our trust was very good at kind of promoting these safety huddles, which we continue with our team every day, where it's just a quick get together in the morning, check in that everyone's okay, if there's any support or anything work related, patient related that needs to be discussed as well. Let me just go to the next slide. Here we go. So what I found quite interesting, I kind of documented throughout the groups that I did what the themes were, you know, because generally everyone was kind of falling into these groups of different feelings and emotions. And it was quite stark, the difference between what we would call the first wave of COVID and the second wave, which kind of was later sort of January, you know, the December, January period last year. So for the first wave, I think probably one of the most prominent fears and anxieties was redeployment. And I'm sure there's some people listening today where that might ring a bell with them, because particularly for the CNSs and the specialist nurses, a lot of them hadn't worked in the ward environment or inpatient led work for, you know, 10, 20 years in some cases. So it was a case of, you know, having to sort of do all this e-learning, being fit tested, all of this, you know, horrible sort of imagery in their head going on ICU, all of these really critical, stressful environments when they've been working in outpatients, which is obviously a very different pace to being on the ward. And then I think in particular, you know, I myself as an OT, I went to work on the oncology ward to do some shadowing, and actually it kind of, you know, in the nicest way, came to nothing for the first wave because it just got very quiet. So it was almost preparing and anticipating for this thing that didn't really happen until later on. So that led to a lot of anticipatory anxiety, a lot of worry, a lot of stress, and then kind of calm down again, but always feeling on edge and that you're going to be called to duty, as it were, when, you know, for a lot of us, it didn't actually happen that way in the end. And then the other theme that was kind of quite paramount in the groups that I ran was this whole concept of the clapping, you know, the NHS heroes. There was a lot of support for it and a lot of people that were very appreciative that, you know, they were getting that recognition. But I think it, in a way, it was divisive in terms of saying, okay, well, you're on the front line doing this, and for us that were kind of more office based, not really on the front line and perhaps quieter because we couldn't actually see our patients, it did kind of make them feel, you know, not as worthy of the claps. And, you know, it did get to the stage where it did make people feel a little bit uncomfortable, I think, in certain staff groups. And then the other, you know, themes, taking it back to vulnerable family members, that was a really, really big theme that actually stayed the whole way through the first and second wave. As the infection rates changed, they plateaued and then increased again. And then in terms of kind of practicalities, the amount of staff that had to shield, and obviously how difficult it was for those staff shielding at home, but the impact on the remaining staff members who weren't shielding. So they were kind of left on the ward, short-staffed, and, you know, that kind of unwitting, I suppose, resentment, which, you know, some people did admit to me as reluctantly that they did feel, you know, I've been left to deal with all of this on the ward. But obviously it was no one's fault, it was just the situation. And then at the very beginning on the oncology ward, we did a lot of sessions with the newly qualified Band 5 nurses, who, again, because of the staff shortages, were taking on a lot more of the managerial roles than they would have normally been expected to have to deal with. So that was very difficult, and they were kind of in charge of a shift, you know, feeling very, very stressed. They'd only, you know, qualified 6 months ago. So that was very, very difficult for them. And then lastly, staff who have family abroad. So a lot of nurses from Thailand or, you know, Eastern Europe who hadn't been able to see their families for a long time anyway, and knew that they probably wouldn't be able to for the next year, you know, what the COVID situation was like in that country where their family were. So that worry of not being able to see them, as well as not having them for support themselves. Okay. Oh, wonderful. Thank you. Yeah, and so the second wave theme, so it kind of took a bit of a shift, I think, emotionally, from my experience anyway. And it did kind of turn from more the anxiety of what's going to happen and the uncertainty of what's going to happen to, you know, we've had all this support, all this clapping, all these kind of, you know, you don't have to pay for parking, all that sort of stuff. And then it kind of disappeared a little bit, or it appeared to. The government weren't kind of promoting that message as much, our staff felt, as previously. So I think there was a lot of anger, a lot of frustration, as well as the fact that everyone was just really tired and, you know, physically exhausted, emotionally exhausted, very fed up generally with the situation, and, you know, having to sort of adapt constantly to what's going on. One of the things that one of the physio groups brought to the session was the different attitudes about the PPE requirements. So they were finding that a lot of the staff on the ward were quite flippant in a way about how much PPE they would wear, because they were under time restrictions. They just needed to kind of get the work done, and the physios were very much like, no, we need to spend time putting this on, doing this properly before we can do an assessment. So I think there was kind of resentment again building between different staff groups on their take on the PPE. And then again, obviously I can only speak for our trust, but the JR, I think we can say objectively, did have more COVID cases than we had at the Churchill at certain points. I mean, I haven't got the figures for the whole 18 months, but I think generally the feeling was that the JR did have it a lot worse than we had it at the Churchill. So again, that created a little bit of resentment from staff reports. And then kind of the themes that I guess we all deal with generally in this job, the difficulty of being able to switch off when you go home, that kind of became more exasperated, because again, you were having to go home and, you know, have a shower. So not just the normal, I'm trying to forget about my day at work if it's been stressful, but the physicality of having to sort of, you know, take your uniform off, wash it, you know, all this sort of stuff on a very sort of extreme level was very difficult. And then lastly, and I think this was one that kind of hit towards the end of the second wave really, the palliative patients, or, you know, patients who were dying on the wards, you know, that's difficult enough when they're allowed to have their family members and friends with them. But the staff were essentially you know, at certain stages, the only people that were there to support them and be there when they died. And they found that very, very difficult. The nurses reported to us that was a really hard part of it, knowing that, you know, they could stand outside in the car park and wave through the window, but effectively they couldn't come on the ward for a very long time, at the most difficult part of their life, really. On to the next one. There we go. So in terms of what we offered, and I suppose this has kind of all been in the later months really, so this is I suppose has progressed since the beginning. So we've got a new head of wellbeing who's been appointed, so we've done a couple of focus groups over the last few months. I think really to get the message across that this is a really difficult job to do all of the time, and obviously a pandemic does, you know, increase the stress and all of that, but, you know, we should be offering our staff good support the whole way through, really. It shouldn't be that it's just a crisis situation that provokes a lot of these responses. So in terms of our trust, again, you know, there's mindfulness, there's webinars, the psychiatrists and the psychologists in our team do a lot of talks online about specific things like stress, sleep, you know, specific problems. And we do have wellbeing leads for each kind of department now, which are kind of a vocal point for all the staff to sort of go to if they've got any concerns or questions. I'll just go to the next one. So yeah, I just wanted to put this on because this was kind of the poster that was sort of shoved everywhere from the beginning, really. So this was on toilet doors, downstairs, in offices, and it kind of just highlights, I think, all the different ways that the trust was trying to support staff. So obviously it's got the kind of practicality stuff of the discounts that you get in the supermarkets and restaurants and things, the accommodation, the parking, but then obviously down this left-hand side, you know, the talking therapy, the employee assistance program, Occupational, Samaritans, all that sort of stuff. So just that was kind of plastered everywhere, I think, from pretty much the very beginning of the pandemic. So people, you know, if they were so busy, you know, we all have to go to the loo. So having that time to sort of look at that poster and take what they needed from it really was quite helpful, I think. I'll just go on to the next one. Lovely. So yeah, and I think the other thing that we had a lot of reports of was managers struggling to deal with the queries that were coming from their staff, because firstly, they were probably struggling, well, they were struggling themselves anyway, but also knowing where to signpost people to. So obviously we were always there as a guide, and, you know, in Psych Med, we were always happy to sort of speak to managers about how they can best support their staff. But I think a lot of it was just, you know, identifying the level of distress and what was needed. That was really difficult for managers to kind of identify sometimes, because a lot of it could be, you know, as written here, encouraging simple self-care, like, you know, having a bath, seeing, you know, doing video calls with your family, looking after yourself, getting good sleep. And I think it was knowing when that tipped over into, okay, this is actually something more serious. And people with pre-existing mental health conditions like depression, anxiety, obviously this was a key trigger for a lot of those people. So again, the employee assistance program and occupational health are really good ways to start, but sometimes it was a case of, we would advise they would speak to their GP, they would consider, you know, other options, talking space. On our intranet page now, we do have a really amazing list of all the different organisations that you can go to for, you know, lots of different conditions, not just depression, anxiety, but, you know, help with financial problems or addiction. I think it's kind of made everyone realise that we need to be very holistic and look at everyone's different needs and what we can offer them, really. And there's my little bee with any questions, which obviously is a bit redundant because I know we've got the Q&A, but that was kind of it.
Hi there. Thank you so much for that, Sam. That was really, really.
Oh, that's a pleasure. Sorry, I'll mute myself now. I don't know.
Oh no, don't. We've got questions and comments for you. I mean, actually, just looking at a comment we've got in the Q&A box there. It just says, it's not a question. I just want you to know it's been so nice to hear this session and realise I was not the only one who felt like this. The fear of redeployment combined with the guilt of not being redeployed. I just think it's so important, isn't it, to have the time and the space just to say this.
Absolutely. And I think that was probably one of the feedbacks we got the most of. It was having the time away from the work environment. And for a lot of people, they didn't actually contribute, which was absolutely fine. But it was just that shared experience and knowing that they're not the only ones. There's such power, I think, in knowing that you're not going through this by yourself, which of course we all talked about and everyone was on Facebook saying, you know, we're all going through this. But I think when it's so specific to your profession and when you're seen as this kind of hero, angel, you know, part of our role is to be that most of the time anyway for people. So I think it was really, the pressure was, I think, on healthcare professionals in a very different way, and that they found that very difficult.
Sam, can I just ask you, you know, you're obviously dealing with a lot of stress from other sources. How do you, as a team and individually, deal with your stress related to all of the work that you do, as well as the COVID-19 work you've done?
Yeah, no, that's a really good question. So we have, so there's 5 of us in the team, well, 4, so there's 3 specialist nurses and me as an OT, and then we have 2 psychiatrists that work with us now. So actually our staffing was very low during the pandemic. It was effectively just me and the consultant psychiatrist. So in a way, although it was challenging, we had a very good sort of debriefing session most days, to be honest, where we talk about how we were finding things, and that was really valuable. But since having more nurses in the team, it's been super amazing to be able to have regular supervisions where we talk about our own well-being as well as patient cases. So I think we try, and like I said, we've carried on with the safety huddles the whole way through. So I think for me, it's about not saying, okay, the pandemic happened, it's raised a lot of stress, a lot of anxiety and difficulties. Actually, these jobs are really hard to do all the time. And, you know, we always have this kind of thing, well, you know, it's our job, we'll put up with it. But actually, if you don't talk about it with your colleagues, it's really difficult because, you know, you're working from home now a lot more, so it's a lot of solo working. And I think it's just trying to encourage the communication, which is what we do in our team. Obviously, we talk about mental health all the time. You know, I know it's very different to the other teams, so that's not, you know, their main focus. If we're not talking about our patients' mental health, we're talking about our own mental health. And I think individually, again, for me, it was a lot of the self-care stuff. Like I said, it's not really difficult things to do. It's about having good sleep, about doing things that you can were able to do that you enjoyed doing, adapting them as much as you could, speaking to friends and family regularly, you know, exercise, all this stuff that we bang on about all the time for our patients, but we're very reluctant to do ourselves because, you know, we don't always make time for it. We don't see it as a higher priority, or we have families, other responsibilities. I think sometimes, again, healthcare professionals, we put ourselves at the bottom of the pile because we're looking after other people so much. And actually that can be really detrimental to us, but our patients as well, because if we're not looking after ourselves, you know, we're no good to our patients effectively. So I think, again, for me, as you can tell, I love talking about mental health. It's really just about talking about it. I think that's the best thing you can do. And just asking, you know, from a patient perspective, just asking questions that they might not have been asked by their consultant, nurse, GP, whoever. And we're very lucky to have that opportunity in this trust to do that. But within our teams as well, just asking, you know, are you okay? You seemed a bit quiet. I didn't see you talk on the Teams call, you know, and not being afraid to do that, because there is still this stigma of, you know, oh God, it's depression. What do I say if they say, oh, I feel really low? But actually, sometimes you don't need to say anything. You just need to listen. And that's more than enough, really. So that was a very waffly answer, Tracy.
Thank you for that, Pam. Is there any more questions, Catherine?
Yes, well, yes, we've got, I think, a really interesting one.
Yeah.
It says, what does the future hold? Seems to be ongoing, which I think we can all completely identify with. And will the information that you've gained actually be given to government or passed on so that, you know, somebody can do something with it?
Wow, that's a huge question. I wish I knew the answer to that on a grander scale, but I mean, I hope so. And like I said, I think for me, it's not about this one-off thing that was triggered by a hugely unprecedented global thing. I think it's about making the conversation constant. You know, like I said, our trust, they do appear to be taking this very seriously, the whole concept of well-being of staff. And we're talking about different ways to reach out, apps on people's phones, trying to make it accessible to everyone. And, you know, the government do, you know, say mental health is a priority. Obviously, it's difficult to see sometimes, but, you know, that is supposedly one of their priorities. So hopefully if they can see from an NHS level that the staff are doing that, you know, I would like to be able to see into the future and say they make it a really firm strategy, but obviously you never know with the government. But definitely from an organisational level, I feel very confident in Oxford that we're doing a lot for staff wellbeing, and hopefully it will carry on far into the future.
Definitely sounds like you are.
Yeah, absolutely. I mean, one of the things that's really concerning for us as an organisation is the workforce. Obviously, you know, going into the pandemic, that we didn't have enough people working across the bowel cancer pathway. And that's only been exacerbated by a number of factors that have happened in the last 18 months. And so it seems to me that what you're doing here is an absolutely critical element of retention. Who are already here, regardless of whether, you know, we've got the money or the wherewithal to recruit and train new people going forward. And so I would hope that the focus that you've had doesn't just melt away after COVID, sort of, you know, it becomes less of a critical issue and people sort of forget about the critical importance of looking after workforce.
Absolutely. And I think, like I said earlier, what was really saddening for me was the newly qualified band 5s at the beginning of this, because I know for a fact that a few of them did leave very soon into their roles because, you know, it was just too stressful. And, you know, no one could have predicted this in terms of the managers. You know, the support was given as much as it could have been. But in terms of staff retention, if you don't look after your staff, and we all know this isn't rocket science, people are going to, and so you have to give them the best incentive to stay, which isn't, you know, none of us do this for the money. So it has to be the well-being, looking after people, as well as the patient care. You know, I think it's Richard Branson that said, you know, the clients aren't the most important people, it's the staff.
Yes.
For the NHS, I mean, essentially it's a business of sorts. And if we don't look after ourselves, we're going to be absolutely useless for our patients. And the patient, you know, if you're having a bad day, the patient knows that you're not giving them the best care you can. So I think absolutely, I agree with you. I hope that it's not just a flash in the pan. I hope this is taken as, you know, we've been waiting too long to appreciate our staff in this way.
Absolutely. Do we have any more questions? I think we've got, I mean, yeah, just, you know, comments in the chat about how really good it is just to hear that there's common ground that everybody's felt over the past 18 months. And I do hope, you know, as we've said, that this isn't something that just melts away and people don't need to focus on as we go forward, because actually I think, you know, as you say, smart employers know jolly well that if you look after your staff, you can recruit and retain your pick. And so it's a really important area of work. Been fascinating.
Yes.
Absolutely fascinating. I was just very struck by that poster that you showed us that, you know, you said was everywhere. It's all over on the back of toilet doors and things, and just the amount of information on this,
yeah,
well, just to digest for people.
Well, I think, and that was a problem in itself, because it was so overwhelming that actually if you were struggling psychologically, that you didn't really know what part of it you were finding difficult. As much as it's great to have the information there, we did have a lot of people come to us and say, I don't really know where I fit in this because I'm feeling this, I'm feeling that. But, you know, that doesn't really help me. Occy health isn't the best thing for everyone. Sometimes it is so individual to other circumstances, not just COVID, which, as I said, is why we always were there to sort of offer signposting if it was a more serious mental health concern. But yeah, sometimes you know, you need the help. There's an outcry for it. You throw all this stuff at it, but it doesn't always help. You need to be very specific in what you're signposting people to.
That's brilliant.
That's great.
Yeah, no, thank you so much for that.
Oh no, it's a pleasure. Thank you so much for inviting me.
And if anyone else has any questions for Sam that occur to you afterwards, please just do let us know and we can pass that on.
Absolutely.
Tracy, any last words from you?
I'd just like to say thank you ever so much, Sam. Obviously, we work at the same trust. We've not actually met each other yet.
I know.
I look forward to meeting you one day.
Sam, Tracy.
Thank you very much. It's, you know, I've seen some of the changes that they've made in the trust. I've seen some of the posters, and they're going forward and doing wellbeing check-ins now, which is all really positive for the future. So, you know, thank you for your part in all of that. Thank you.
Oh, it's a pleasure.
Sounds like you two need a well-being coffee.
We do. I think that's a very good idea.
Where you both make the most of your 50% off Hotel Chocolat. We're all really jealous of that now. Lovely. Thank you, Sam.
Thank you.
So back to us. And if you cast your minds back to a bit earlier on, we asked, I think it was Claire who asked for some feedback through some polls around how the NCCNN network can best support you as its members, and then how you'd like us to communicate with you. So we have the results of those questions in. An overwhelming 92% of people who responded said that they'd actually like more virtual education and training as a result of the partnership between the network and Bowel Cancer UK. So we're going to ask in a moment another question about that, just to elicit a little bit more information about how we can best provide that to you and you know, how you'd best like to receive that. And then we also asked how we can communicate with you in the most effective way. And I'm not going to lie, the results of this one caused a few wry smiles, because 86% of you who answered said through an email newsletter. So some of you will know that that's how we have been doing it for the last couple of years, and we actually stopped doing it earlier on in this year because our results were telling us that only about 5% of them were actually being opened, and we wondered if it was actually the right way to be contacting you all. So it's interesting to see that that is actually your preferred way of hearing from us. So we're just going to ask another question about that again, just to find out how often you'd like to hear from us, just so we can get a sense.
And maybe, you know, it'd be really good to know if you feel like telling us, you know, how we can make the content more relevant.
Absolutely.
You know, how we can make that email that bounces into your inbox and you go, oh, must read that, put the kettle on.
So if we can have that poll back, that would be great. We'll leave it up for a few seconds for people to have a read and choose your answers. And then if you've got thoughts on content, do feel free to stick them in the chat, and we'll collect those too. I was about to say nobody's brave enough to go first, but somebody. What you can't all see, I don't think, I don't know if you can see, but we can see your results coming in. So we've got blue lines.
Going up and down.
Going up and down. Very We're getting quite a lot of support for shorter, more regular sessions as opposed to once a year study day. There's a third question on there about how you would like to network with your peers, because quite a few people indicated that was something that maybe the network could help with. So that's great. We'll just leave it. Oh no, we can't leave it running because I've got slides. So I think that's great. If we can bring that to a close. Thank you for
thank you to everybody who took part in that. All helps us to make these things better, more relevant, absolutely, more timely for you, which we're obviously very, very keen to do.
Brilliant. Okay, so now on the agenda is just an opportunity for us at Bowel Cancer UK just to showcase to you, to those of you who perhaps are new to us as an organisation or perhaps haven't used our resources recently. We just want to sort of update you on the work that we're doing and the services that we offer that can really help support your patients. Perhaps you could signpost to them. And the patients can make the best use of the amazing support that we have. So first up, am I in control? Yes. So we provide expert information and support for everyone affected by bowel cancer. We offer peer support as well as educating health professionals and the public about the disease. So if you want an overview of all of our services, then you need to go to our website and you can click on the How You Can Help page and there'll be lots of signposting links there. We're going to start just by talking a little bit about our online forum. And as you can see, there's an online community button on our homepage, so it's quite straightforward to find. It currently has over 6,000 members. And once you join, you can dip in and out to various themed chats, such as Just Diagnosed, or somebody might ask a question that might start a thread. There are separate chats for younger people with bowel cancer, and then there are private groups within the forum for caregivers and friends and family who are experiencing a recent bereavement. We also have our Facebook groups, and again, these are closed groups, and we run those at the moment for caregivers, for those people living with a stage 4 diagnosis, and we have just added an immunotherapy support group to our portfolio. There are plans next year to add a couple more Facebook groups. So again, if you've got particular groups of patients whose needs you don't think are being met through either our services or other services that are out there, then do let us know in the chat, because we're always open to new ideas as to new groups we could have or new chat groups we can have within the forum. We also run our Ask the Nurse service. So again, that's nurses who are available via an email service to answer slightly more complex questions that patients might have. So that's at nurse@bowelcanceruk.org.uk. So again, you can tell your patients about this. Perhaps when they get home, they've had a chance to read the information they've been given by you, think about the conversations that they've had with you and with consultants. And then if they've got questions, they can always email our nurse and have a dialogue that way to get the answer to their question. We also have our online support groups, Chat Together. So they are 8 people will meet for sort of 6 hours over 6 weeks, come together in a facilitated environment, supported by staff, by trained facilitators, to just share experiences, answer each other's questions, offer peer support over Zoom. We are currently running stage 1 to 3 groups, an advanced bowel cancer group, and we are on the verge of starting one specifically for patients in Wales, and details of all of those are on our website. So quite new for us this year is some work around patient engagement, and we're kicking this piece of work off in Wales because we've had some funding to do it specifically in Wales. And this is about forming a group of bowel cancer patients who come together and want to use their experience and their views and opinions to feed in to development of services across Wales. So we're working with a number of partners, working with the Moondance Cancer Initiative, and then through that with organisations such as Wales Cancer Alliance, to really find out where the points on the pathway are that patients in Wales are having the worst experiences, and then working with the patient group and the clinicians to just, you know, try and improve services by bringing that patient view in and enabling the changes to be really co-designed with patients. So if you are based in Wales and have patients that you think might like to get involved in that group, you can contact my colleague Sian, and her email address is there, and we will send this round afterwards. We also do awareness talks, and we provide awareness talks both face-to-face and virtually for free to workplaces, community groups around the UK. We're always looking for awareness talk volunteers. So if you've got patients who you again think they would absolutely benefit from, you know, being involved in something like this, giving some of their time to help us spread the word, then you can contact my colleague Ross. Equally, if you in your lives outside of work would like awareness talks, would like one to be held somewhere, perhaps at a local golf club or don't know, Women's Institute, that's what we call it, isn't it? Yes, your local Women's Institute, or just your local wherever. You can go onto our website and you can book an awareness talk. And we have our next patient event coming up. So following the success of our event back in June, I think it was, we received a terrific amount of feedback that patients who attended that really got a lot out of the day. And one of the themes that came through was that perhaps patients with an advanced bowel cancer diagnosis would appreciate having the space and the opportunity to have advanced disease focused on more specifically, rather than them trying to ask their questions alongside patients who perhaps have stage 1 to 3 disease. So we are running a Living Well with Advanced Bowel Cancer Day on Saturday the 6th of November. It's completely free for patients, friends and families to join. Agenda hasn't been completely nailed down yet, but it will involve things to do with involvement in clinical trials, treatment options, side effects, and just the sort of psychological elements of managing an advanced cancer diagnosis. So again, for more information and to signpost patients to that, you can visit our website where you'll find all of the details on that event. And we're hosting, aren't we, Jen?
Absolutely. Absolutely. We didn't miss it.
No, lots of cake last time. So
and yoga.
And yoga, cake and yoga last time. And then we also have our health information. So if you're not familiar with our health information, I would absolutely recommend that this is the first place you go on our website following this event. We stopped print production last year because we had to watch the finances and be mindful that our income may not enable us to have printed in the volume that we did before. However, we are now able to turn some of that back on. So we've identified those booklets that we know are the most popular and make the biggest difference. So we are a couple of weeks away from you being able to start reordering printed copies of Your Pathway, Eating Well and Treating Advanced Bowel Cancer. And then once younger people with bowel cancer and your operation have had their review, they too will be available. You can also download all of our publications in PDF format, and we've also got animations and some short videos as well for you to signpost patients to. Just giving a quick overview of some of the work that's happening outside of support services. Obviously, our policy and campaigns team are working really hard to monitor the recovery of bowel cancer services across the UK, focusing mainly on diagnostic waiting times for endoscopy services and cancer patient prioritisation during any future peaks of COVID-19 and the challenges of the winter for the NHS. Also working really hard with other cancer charities through One Cancer Voice and through the APPG on cancer to submit to the Treasury in terms of asking for more funding to train more staff and buy more kit in cancer services to help increase capacity. And that spending review is coming up, isn't it, in the next few weeks. So we're pulling together our submissions for that.
Our submission has just landed in my inbox for
there
me to
you
look
go.
at later on. Thank you.
Also, our policy and campaigns team are working on optimising bowel screening. We're a member of the National Programme Board in England and therefore are able to influence the implementation of the age extension and optimise the programme further to include testing and surveillance of Lynch syndrome, which we heard about earlier, and also sitting on various optimisation and steering groups to help improve the service. And we now have the Northern Ireland Cancer Strategy out for consultation. We've been involved in various working groups that have helped inform this strategy in the run up to this, and are again in the process of pulling together a response ahead of that final version. So if you are interested in finding out more about that, you can head to our website where you'll find details of how to get involved. And I'm so sorry for the C word appearing in, what are we? We're not even in October.
Tomorrow.
No, the Friday,
Oh,
29th today.
This week.
But it is beginning to look a lot like Christmas is heading towards us. So we've got our brand new Christmas merchandise available in our website. We've got some lovely tree decorations.
Christmas cards.
Beautiful Christmas cards.
My favourites. I have to say,
Candles.
These Christmas cards, I'm embarrassed to say, these sold out last year before I bought any, which as chief executive
That's quite an admittance, isn't it?
It is, yeah. So I'm getting in there early this year, and I hope you might too. We've got some lovely designs on the website.
We also have a Quizmas challenge coming up on the 2nd of December if you're interested in joining us for that. Free to enter, but donations received will be doubled.
Lots of our celebrity supporters will be hosting different rounds on that, so it'll be a huge amount of fun.
And just to incentivise you to visit our shop where you can check out our merchandise, there's a special 10% code this week, anything purchased, and that's Blue Bolt or Blub Alt.
Blue Bolt.
Is it Blue
Bolt?
Bolt
Is a fabulous company that did our online shop for us free of charge in memory of the owner's sister who died.
Ah, there we go. Not Blub Alt.
Blue Bolt. And so we're very grateful to them, but we've got 10% off this week and there's some really great things in there. I love those t-shirts. Nigel Hall designed them.
Yes, they are beautiful.
Yeah, I've got two.
And so visit this week, use your Blue Bolt discount code, but then the Christmas stuff I think hits around the 21st of October.
Yeah, this is a bit of a preview. It's not there yet, but it's on its way.
But then there will be another discount code. Because we want you to all buy Christmas cards.
And not before I have them.
No, not before
Not
Jen.
this year. Yeah. I need to get on with that.
So that's a fairly shameless plug, I think, for our services and our fundraising efforts. But you know, we really do appreciate your support. I know that lots of you take part in various fundraising activities for us. I can see somebody's running the marathon on Sunday for us. Gail, brilliant, thank you. We'll be there at the various cheer points cheering you on.
Yes, I'll be there, Gail. Good luck. And that's an incredible effort, having done a half myself and then not walking properly again for about 3 months afterwards. So my hat goes off to you for that. That's incredible.
Right, it's that time, Jen.
It is.
It's Gary Logue time.
I know, we're bang on time as well, aren't we? Well, it's my great honour this year to kick off this bit of our meeting, which is the much anticipated Gary Logue Awards. And as many of you will know, the awards were established in memory of Gary Logue to honour his remarkable contribution during his career. Gary worked for us as a specialist nurse advisor and he passed away in 2014. So we have 2 awards marking the achievements of some very special nurses who make a huge difference to both the lives of their patients and their colleagues. And one of those awards is nominated by patients and the other one by their colleagues, which I think is incredibly special. The winners will receive the award, a certificate, £300 towards their professional development. And this year, we've got, thanks to a very generous donation from Mary, who's also known as the Silver Sprite, we have 2 unique pieces of jewellery celebrating the NHS using the rainbow that we've come to associate with hope during the pandemic. And I hope Catherine is just showing you those. I hope you can see them, but they are absolutely beautiful, really beautiful. So thank you so much to Mary for that. That's very kind. Now, the standard of nominations was extremely high. And I must say that you are a winner if you were nominated, because again, it was very, very high. But we made our panel choose a shortlist, and the winners have been a closely guarded secret. That is until now. So I'm delighted to hand you over to the wonderful Charlene White. She is our patron. You will know her from Loose Women. She's an ITN news journalist and TV presenter, an all-round fabulous person. So Charlene, over to you.
Hello, and thank you, Jen, for the introduction. I'm excited to be announcing the winners of the 7th annual Gary Logue Colorectal Cancer Nurse Awards. As many of you know, the award was set up in honour of Gary, a nurse who worked for our charity who sadly passed away in 2014. This award is incredibly important to me. I came to the event back in 2018 with my then baby son to hand out awards to the winners. As you no doubt know, my mum died from bowel cancer in my early 20s, and the kindness and support nurses gave her and us as a family for many years will never be forgotten by us. We asked healthcare professionals and patients to nominate their inspirational colleagues and colorectal cancer nurses, those who make a huge difference to the lives of everyone they reach. All those nominated have demonstrated exceptional care throughout the challenges of the pandemic, going above and beyond for their patients, and for that, we thank them wholeheartedly. The finalists for the award for a nurse nominated by their colleagues are the colorectal nursing team from Salford Royal NHS Foundation Trust, Felipe Carvalho from the Royal Marsden NHS Foundation Trust, Claire Stevens from Lancashire Teaching Hospitals NHS Foundation Trust. And the winner is Felipe Carvalho. The nomination we received for Felipe said, Felipe's role involves supporting patients with a variety of advanced colorectal cancers who require, amongst others, surgery such as total pelvic exenteration. He is a perfectionist when it comes to patient care and splendidly proactive in ensuring constant provision of effective, safe and high-quality care, along with high patient satisfaction. He's an asset to the Trust and has a key role within the team, which includes assessment and formulation of clinical decisions and management plans by independently using advanced clinical assessment and diagnostic skills to provide ongoing care and treatment. Recently, he showed outstanding leadership skills and was instrumental in setting up the running of the COVID Cancer Hub, which saw over 200 patients with colorectal cancer from hospitals across our network undergoing surgery in 2 COVID-free hospital sites. Well done, Felipe.
Absolutely huge congratulations, Philippe. That is wonderful. Here is your award. I'm so sorry that I can't give this to you in person, but we will make sure we get it to you. And along Catherine's got the certificate. It's a lively one, Philippe, I must say. almost dived out of the box. But so well done, so heartfelt and well deserved. And we will get those to you soon. But say a few words. Speech.
Thank you, Catherine. Obviously, I wasn't expecting the award before, for all the attendees to know, before I actually joined the steering committee of this conference. I only found out the day before that I had been nominated by one of my colleagues. But, needless to say, the fantastic or the work that I do, the way I help the patients, can only be done through all the help of my colleagues and the fantastic team that I work with. Regardless if I try my best or not, I can only achieve the outcomes I achieve with the help and support of my colleagues. So thank you to all of them.
Well done.
Well, huge congratulations from us, and thank you again for everything that you do. It means so much to everybody who works with you and is touched by the work that you do.
Thank you.
So now I think we're going to go back to Charlene to hear about our second nominations.
The finalists for the award for a nurse nominated by patients are Anne Monje-Garcia from St Mary's Hospital, Imperial College, Healthcare NHS Trust, Anne Lauder from Glasgow Oncology Clinic, BMI Ross Hall Hospital, Lauren McCriskin from Addenbrooke's Hospital, Cambridge University Hospitals, NHS Foundation Trust. And I'm really pleased to say that the winner is Lauren McCriskin. The nomination we received for Lauren, sent in by a patient, said, "Words can't describe how much Lauren has supported me throughout the last year and a half. Throughout this extremely terrifying journey, Lauren has been there as my rock every step of the way to calm me, support me, inform me, and all with such kindness and compassion. She always talks the honest truth, even when that is difficult. And trust me, it has been. But she has an amazing way of communicating the medical information while still making me feel cared for, listened to and supported. She has rung me with medical news way past her working hours just because she knew I was waiting to hear and was nervous. She never ever makes me feel like I'm a bother or that I'm wasting her time. She's always there on the end of the phone, even now that I am thankfully on surveillance. And I still appreciate knowing that she's always there for me. I can't thank her enough. She honestly has been an unbelievable light in this very dark journey. Oh, and her sense of humour is pretty epic too. So huge well done, Lauren, and well done to all those nominated and all the amazing winners. Thank you so much for everything you do.
We're on mute. Lauren, congratulations. We are so thrilled. Here is your award. And again, I'm so sorry not to be able to give to you in person, but we will make sure we get it to you as soon as possible. And what a heartfelt tribute that was. And just a really special thing. Now, Lauren, you're here. Do you have to come and say a few words?
I'm shocked to even be nominated, let alone to win. So thank you very much. But absolutely, it's for the whole team, because I wouldn't be able to do the work I do without them.
I'm really tempted to ask you to tell us a joke after your sense of humour got a massive shout out, but I won't embarrass you. Just amazing. Well done.
Thank you.
Yeah, thank you for everything that you do on behalf of patients, and to all our nominees who are doing phenomenal work. And to all of the network. Exactly. In particularly in the last year, very, very trying times. So thank you to you all. We will get those dispatched to Lauren and to Philippe.
Yes.
And thank you again. I'm going to hand over to Catherine just for some little closing bits for the end of the day, but it has been a wonderful day. Thank you to everybody who's contributed and asked questions in the Q&A in the chat. We will get back to you. Catherine.
Brilliant. Thanks, Jen. Well, I'm not going to keep people for too long. We will be sending out an email in the coming days with the evaluation of today. So as I said earlier, it would be amazing if you could fill that in because we will use that information to improve things and make this event even better next year. So I want to say a massive thank you to everybody who's been involved in today. That's the steering group, so Philippe, Tracy, Claire, to our speakers, Rebecca, Laura and Sam, to the Bowel Cancer UK behind the scenes team. Hayley and Richard have been your seamless controllers behind the scenes, making sure that Jen and I appear when we're supposed to and you can't hear us when you're not supposed to, and also making sure that all of the videos and everything else have worked, so and the slides. So a huge thank you to them. A massive thank you to Charlene for the Gary Logue award videos that she did. Thank you to all of you for coming, and well done to our winners. And I think that's probably.
And just a last shout out to Servier, our funders, for being so kind as to make this happen. And we hope that it won't be too long before we can see some of you in person. But in the meantime, we'll make sure that we still keep in touch.
Absolutely.
Like this, because this is great too.
Have a lovely evening, everyone. And well, we're off to eat cake, aren't we? We always end these events with cake.
There is some cake.
There is some cake.
Yes.
Take care, everyone. Bye.
Thank you. Bye-bye.